Mucopolysaccharidosis can be classified broadly into two broad categories: the systemic variant and the localized variant. Systemic variant has too many names: Hurler, Shy, Sanfilippo. All these can come very easily in the exams and are very important. The localized form is the macular corneal dystrophy, and you'll see right now how similar these findings are. The localized form has no systemic associations at all. It's just a corneal dystrophy. And if you remember from the cornea literature review lectures, it's autosomal recessive, in contrast to all other stromal corneal dystrophies which are autosomal dominant. And this makes sense because mucopolysaccharidosis all are autosomal dominant except Hunter syndrome, which has X-linked inheritance pattern. We'll start with mucopolysaccharidosis type 1, Hurler syndrome. It's due to accumulation or excess heparan and dermatan sulfate. It's usually overt by the first year of life. This child shows short stature, dysostosis multiplex, organomegaly, facial dysmorphism, and the facial dysmorphism is just like the general manifestations that we just mentioned. So frontal busing, shallow nasal bridge, usually not true hypertelorism. Number 2 is dysostosis multiplex, and we'll discuss this further now. In the MCQ questions, dysostosis multiplex comes usually in the form of thickened clavaria or J-shaped sella turcica. So the MCQ question discusses, for example, a 2-year-old child presenting with corneal opacity, behavioral changes, psychomotor developmental changes, and we performed X-ray on the skull and we found thickened clavaria and J-shaped sella turcica. This is a J-shaped sella turcica. This is a normal, and this is J-shaped. J-shaped sella turcica, it's this slope. It might happen as anatomic variant in 5% of cases, but the other important part for ophthalmologists is it happens in optic chiasma glioma. I'm not aware of any candidate in part 3 or the oral part of FRCS who was presented an X-ray with a J-shaped sella turcica, but you need to be aware of this differential diagnosis. Anatomic variant, optic chiasma glioma, neurofibromatosis type 1, mucopolysaccharidosis. So this is what we mean by dysostosis multiplex and facial dysmorphism. And there is another important term that we encounter a lot in FRCOphth and FRCS questions, the cynophorus. Cynophorus is having a single brow rather than having two brows. This patient has cynophorus, so he has single brow. Cynophorus usually happens in mucopolysaccharidosis and mucolipidosis. The most common cause for cynophorus is Cornelia de Lange syndrome. Usually this is not very related to ophthalmology, except it causes myopia, causes ptosis, and strabismus. So coniferous, mucopolysaccharidosis, and mucolipidosis, and most commonly corneal syndrome. Systemic features also include organomegaly, and hearing, neurosensory hearing loss, loss of vision due to corneal cloudiness, due to optic nerve lesions, papilledema, and atrophy, due to pigmentary retinopathy, and also due to glaucoma. And here, glaucoma, there is a problem with glaucoma here, because you can't follow up glaucoma in a patient with corneal opacity. And performing penetrating keratoplasty in these patients might not be successful to restore any vision, because this patient might be having glaucoma, optic neuropathy, optic atrophy, or retinopathy. So it's interrelated. I've discussed this more extensively in Hurler's syndrome, because this is the same for nearly every mucopolysaccharidosis. And these terms, dysostosis multiplex, facial dysmorphism, coniferous, they are very related to our MCQ questions. They are very repetitive. Death in Hurler syndrome usually happens in the second decade of life due to recurrent pneumonia or heart failure. And most of these patients, they have anesthetic difficulties, so they are very hard to intubate. It presents with diffuse corneal cloudiness, and as you can see here, there are few spots. Its Hurler syndrome usually is pancorneal, involving the whole cornea from limbus to limbus. Glaucoma might happen, and this is very difficult to diagnose and monitor. There is also progressive retinopathy, which ends by pigmentary retinopathy, bony spicules, and you might not be able to differentiate it from retinitis pigmentosa. Papilledema and optic atrophy are common, and bone marrow transplantation can improve some of the ocular manifestations like corneal cloudiness, optic nerve edema, and retinopathy, but does not help with optic nerve atrophy. Mucopolysaccharidosis type 1S, previously called mucopolysaccharidosis type 5, Shy's syndrome. This is a least severe form, and again it presents with general manifestations, presents with corneal opacity, but this time it's more common in the periphery. So it has central cloudiness as well, but the peripheral cloudiness is very common. So this is not like Alagille syndrome, the intrahepatic cholestasis. We mentioned here in intrahepatic cholestasis, there is peripheral corneal opacities. In Shy syndrome, the corneal opacity is usually peripheral, with no limiting area between the limbus and the opacification. And when it comes to discuss, for example, or study the Arcus juvenilis. Many candidates skip these items, the Arcus juvenilis. So Arcus juvenilis has opacification with vogt interval, a clear corneal interval between the opacification and the limbus. Arcus juvenilis, if you see a child with such peripheral opacity, you need to differentiate mucopolysaccharidosis child syndrome from Alagille syndrome from Arcus juvenilis. This is very important. Glaucoma is very frequent as well. Pigmentary retinopathy, optic nerve swelling, optic nerve atrophy. Hunter syndrome, just the same systemic features. Papilledema, optic atrophy, pigmentary retinopathy, corneal cloudiness. It's more to cause retinal problems, to cause optic nerve swelling and pigmentary retinopathy, like this Optos image to the left. Sanfilippo syndrome is a very common MCQ question. Clear cornea. So corneal changes in Sanfilippo syndrome is rare. Optic atrophy is rare as well. Ocular manifestations are mainly pigmentary retinopathy, and the most common presentation is mental retardation. Morquio syndrome, this is mainly skeletal deformity, but again might have some corneal cloudiness, but usually it's faint cloudiness, and it doesn't usually need PKB. So it's mainly systemic and skeletal deformities. If you look here at the photos of corneal opacities in all these mucopolysaccaridosis, they exactly look like macular dystrophy. They are nearly the same. Grayish deposits and intervening cloudy cornea. Pathologically, they are in the anterior stroma in the center, and peripherally they are involving all layers of the cornea. And this is in contrast to Morquio syndrome, for example. It's more common in the posterior stroma. It's not a high yield information, but just for you to compare between each entity while studying. Maroteau-Lamy syndrome, again systemic features, corneal cloudiness, papilledema, pigmentary retinopathy, might not be discernible from retinitis pigmentosa. Localized mucopolysaccharidosis, so it happens only in the cornea. It has no systemic associations at all. It's the only autosomal recessive corneal dystrophy. It's like the other mucopolysaccharidosis, systemic mucopolysaccharidosis, in contrast to all other corneal dystrophies, stromal dystrophies, which are autosomal dominant. MCQ number 1,